Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call. I'm Dan.
And I'm Vivek.
This is so weird without Ronak. I gotta say, he always starts us off, and I just we were just sitting here looking at each other for like 5 seconds, like okay, one of us has to talk.
Yeah, Ronak needs to be here. The guy, I think he's being lazy. I don't know where he is. He's nowhere to be seen, but there's tariffs happening, so maybe that's why. Maybe he got a little bit, he's a little spooked from the tariffs and just needed a day off. So
just being lazy as usual, always sleeping in, never working that hard.
Yep, classic. So we've got a great episode today. We're gonna talk part 2 of our APLS episode. So let's get into this one.
Let's do it. Well, hello, a duet today. So it's just you and me, Vivek.
Yeah, excited to do this. Now that Ronak's not here, we can cut down this intro way more than normal because Ronak's really into it. And I'm sort of like, I don't know if anyone's really listening to it, but if anyone's wondering, Love on the Spectrum. That's what everyone should be watching right now.
I saw that for like a little poster on Netflix. It's on Netflix, right?
Yeah, it's on Netflix.
Yeah, I thought about checking it out. It's springtime, sort of. It just finished a week of intense storms here at Rouleau University, and now it's better. Okay, I feel like that was enough. Let's talk about our case. So we're still in the midst of antiphospholipid antibody syndrome. Our first episode covered the diagnosis. Definitely go check that out if you haven't listened to it. We talk about how it's very important to have 2 sets of positive testing separated by at least 3 months, at least 12 weeks, before you can say that those are persistent antiphospholipid antibodies, persistent positive testing. And you also need clinical criteria to make a diagnosis of antiphospholipid antibody syndrome, which is what we're talking about in this podcast. So all the details in that prior episode and the show notes associated with it. So definitely go check that out. But yeah, do you want to tell us kind of where we are in the case, Vivek?
Yeah. So just to remind all of our listeners, we had a 35-year-old woman with no significant past medical history who basically came in with a PE. And given the absence of provoking factors, a hypercoagulability workup was sent. We talked about the nuances in that in a previous episode. Definitely check that out because it's really, really important when you think about these cases. Nonetheless, she got this full workup done. And this was only notable to have a negative lupus anticoagulant, negative anti-beta-2 glycoprotein for IgG and IgM, but there was a positive anticardiolipin IgM antibody at 53, and there was a negative anticardiolipin IgG. So she had come to us, we had talked about the idea of APLS, and now we have this patient who has one antibody that's positive. We talked there's a functional assay looking for this lupus anticoagulant, which is not really an anticoagulant, but it just messes with the coagulation test, and so it seems like it's a quote-unquote anticoagulant, prolonging the clotting time, and we talked about the nuances of that in our previous episode. So the functional assay was normal, and then she has one of the 2 antibodies as positive. So now there's this concern that our patient has this diagnosis of APLS. So she was started on a heparin drip after her diagnosis. In light of this testing, the primary team has now consulted you, Dan, from hematology to provide guidance on anticoagulation recommendations. So where do we really go from here?
So yeah, for the purposes of today's discussion, we're going to focus on patients with thrombotic antiphospholipid antibody syndrome. And I'll assume that anticoagulation is indeed indicated. For reference, there are a few different subtypes of antiphospholipid antibody syndrome. There's sort of an obstetric version where it seems to have primarily obstetric complications. There's a microvascular version. There's catastrophic. There's a whole number of different flavors of this condition. But today we're going to be talking about the thrombotic version. In general, the preferred agent for anticoagulation is warfarin, with an INR goal of 2 to 3. A little bit of caveat there. We have to assume that INR means what we think it means. So if they have a lupus anticoagulant that is influencing the PT at baseline, we have to do additional confirmatory testing to make sure that once they're in our initial planned INR range of 2 to 3, that they are in fact as suppressed in terms of their clotting factor production as we think they are.
And Dan, I just want to piggyback off of that really quick before you go on. It is really important when we think about looking at baseline PT and PTT for these patients. You can get something when you start them on something like a heparin drip, and if you're using just PTT monitoring, you can get something called PTT confounding, where your baseline PTT was elevated because you have this lupus anticoagulant, quote unquote, which is really an antibody to phospholipids, and the functional assay requires phospholipids. So if you're binding up phospholipids, it prolongs the clotting time because you need phospholipids to make clot. So it's really just a functional problem, but that will affect your downstream coagulation testing. And sometimes if you have such a strong lupus anticoagulant, it can also mess with the PT assay, in which case you don't want to just trust that prothrombin time INR measurement. We have to do some other techniques to look at that. So Dan, keep on going with this case.
Thank you for going over that. Very, very important, because I was just about to say that patients can be bridged to that warfarin therapeutic INR with either low molecular weight heparin or unfractionated heparin. So you can do a heparin drip, and then you do need that heparin activity level to confirm, again, that you're therapeutic. In this case, the patient didn't have a lupus anticoagulant, or lupus anticoagulant functional testing was negative, so not something that we're concerned about, but it's very good to keep in mind when you're managing antiphospholipid antibody syndrome. There was once a thought that because APLS confers a higher risk of thrombosis, that we should be shooting for that higher INR range, maybe 2.5 to 3.5, just apropos of nothing, just because they have this higher risk. They did a few retrospective analyses looking at this that sort of suggested that maybe these higher INR targets conferred better outcomes. But in 2003, there was a study published in New England Journal of Medicine, we'll have a link to that in our show notes, by Crowther and colleagues, that looked at it a little bit more rigorously with a randomized double-blinded trial. It assigned patients with a history of venous thrombosis who either had a positive antiphospholipid antibodies 3 months apart, so verified that they had these persistent antibodies, to a higher intensity arm of 3.1 to 4, so basically 3 to 4, or a moderate intensity arm of 2 to 3. Their primary objective was to show that the higher intensity dose was more effective than the moderate intensity dose, than the standard dosing. The results showed no difference in recurrent thrombosis at a median follow-up time of 2.7 years, and also no difference in major bleeding. And so basically show that the standard 2 to 3 range is appropriate. With the advent of DOAC medications, of course, everyone wanted to know, are these going to be effective options for our patients with antiphospholipid antibody syndrome? Way more convenient, right? Less testing, less monitoring, no dietary issues. So we definitely wanted to know, was this going to be an option? The first trial looking at this was the RAPS trial back in 2016. It was a randomized controlled open label study. It was a phase 2-3 trial designed as a non-inferiority trial, and it was done in 2 United Kingdom-based hospitals. This study included patients with antiphospholipid antibody syndrome who are taking warfarin for a prior VTE event with a target INR of 2.5, so our standard range. They randomly assigned patients 1-to-1 to either continue warfarin or to transition to rivaroxaban at 20 milligrams daily. They had tried to use a somewhat strange surrogate endpoint called endogenous thrombin potential, or ETP. Ultimately, while they did not meet their pre-specified non-inferiority threshold of 20%, their data overall was suggestive that rivaroxaban could be okay. When we look at the data more closely, follow-up was really only for a short period of time. It was for 210 days, and neither group had any events. This basically did not do anything to answer the fundamental question of DOAC versus warfarin. And there was a tremendous amount of money spent on this trial. The surrogate endpoint was really weird. Really, we need a longer follow-up period to determine if there's going to be a meaningful difference in events. So, Vivek, could you tell us a little bit about a different trial that was done a little bit later that looked at this as well?
Yeah. And I think you brought up a really important point there. Whenever we run clinical trials, sometimes what we say is it's going to take a long time for us to capture enough events to be able to find a difference between 2 arms, or we're going to need a ton of patients to actually see these events if, let's say, the incidence is low. And so in this study, where the thought was, well, these DOACs are going to be just as effective, you need a ton of patients to really run that study, was the thought. So they said, well, why don't we use a surrogate endpoint that we're making up, this endogenous thrombin potential? And there's been no study to show that that correlated with clot or with real clinical outcomes. So like you said, in 210-day follow-up, there were no events in either arm. So there's no clotting events. So you really couldn't say, is one better than the other? And it wasn't powered to answer that question. So you really were left with nothing better than when you started. And I think that's a really big flaw with the design of that study. And that's what really then led us to a more pivotal trial called the TRAPS trial. So this was a prospective randomized phase 3 open-label non-inferiority study conducted in 14 centers in Italy, in which the study group was comparing warfarin, again with that INR target 2.5, because we've now seen previously that 2 to 3 is just as good as higher ranges, compared to rivaroxaban for patients with a history of thrombosis, which was defined as objectively proven arterial, venous thrombosis, or microthrombosis. And each patient had to have triple positive antiphospholipid antibody syndrome. So this meant that they had a lupus anticoagulant, one. The second thing they required was a positive anti-beta 2 glycoprotein. And the third thing they required was a positive anticardiolipin antibody. So they had all three tests being positive. So this represents a very high-risk population. What we haven't talked about is the single hit, if you will, going back to our lymphoma terminology here, a single hit APLS patient was just one of the three abnormalities. They're also not all created equal. The lupus anticoagulant has been shown to have the strongest thrombotic potential and predictive impact. Having just one of the antibodies being positive isn't quite as bad as having the lupus anticoagulant positive, and having 2 or 3 increases your risk of thrombosis even more. And the biggest thing is that 3, having all 3, is by far the highest risk and predictor of both venous and, more importantly, arterial thrombosis. So this is said, hey, let's take the highest risk group of patients, and that's smart. And the reason why that's smart is you'll see more events. So it's just a feasible trial. So the primary endpoint in the study was a composite endpoint of thrombosis, major bleeding, and death. And remember that the non-inferiority margins for these clinical trials are very important, right? So, you want to make sure that is your non-inferiority margin super wide, where you're allowing for a huge detriment in efficacy from one arm versus the other, or is it very narrow, saying that we're going to make sure that this is really about the same as this other treatment? Because this is a rare disease, this non-inferiority margin was incredibly wide. They accepted a 50% loss in efficacy of warfarin, and that's a huge non-inferiority margin. And this was based on studies that showed the rate of the composite outcome with warfarin was about 6% compared to 13% with observation for triple positive APLS patients. So that's where we got this idea that 13% of patients will have a thrombosis or a clotting event within 1 year if they're not on anticoagulation and have triple positive APLS. So very, very high numbers. And the thought was, well, maybe DOACs aren't good. This isn't going to cut it. So that was their non-inferiority margin, which to me is very, very wide, but it did make it more reasonable for patient enrollment. So the trial was designed to enroll 568 patients with stopping rules for futility with a safety analysis. Because if you had a ton, for example, which we'll see, of arterial events in the DOAC arm, you don't want to keep on going. You don't want to have people die from strokes or MIs and things like that. So at an interim analysis, after only 120 patients were enrolled, the trial was actually stopped prematurely due to the worse arterial thrombotic outcomes in patients in the rivaroxaban arm. At the time of trial discontinuation, there were 59 patients randomized to the rivaroxaban arm and 61 in the warfarin arm. They found that ischemic stroke occurred in 7% of patients, and MI occurred in 5% of patients in the rivaroxaban arm, where there were no cases of ischemic stroke or MI in the warfarin group, and there were no venous events in either arm. So it's okay at preventing venous events, but the problem is there was arterial clots. So the arterial events occurred mainly within 1 year of randomization, and most occurred at least 200 days after randomization. 2 of the events occurred within about 30 days of randomization. So there were 2 early events. Most of these events are occurring later on after 200 days. So this shows you that this isn't just an MI, unstable plaque that was going to rupture anyway. This is truly an event that happened because they were on an inferior anticoagulant. There were similar numbers of prior venous and arterial events in these patients, which shows that it's not driven exclusively by those who had prior arterial events before randomization. Because obviously, right, somebody has bad MI, like had 5 MIs prior to randomization, maybe they're going to have another MI just because they have MIs, right? That's not the case in this situation. And very interestingly, most patients had a BMI of around 25. So you can't make the argument these are patients with metabolic syndrome. That's not what's happening here. So it's a true effect. So in triple positive APLS, This trial definitively told us that DOACs are inferior to warfarin. And the problem with this, though, is what about those patients with just a lupus anticoagulant or just an antibody? So, Dan, was there another study? So, TRAP's very clear that we need to be putting patients on warfarin with triple positive APLS. Was there another trial that maybe included other lower risk patients?
Yeah, there is. And I'm glad there is, right? Because we saw, it seems, that even in this high-risk population, DOACs were pretty good at preventing venous events. So they did another randomized trial at 6 different hospitals in Spain, all university-affiliated, comparing rivaroxaban with warfarin. And it gets a little less press than the TRAPS trial, doesn't have that flashy name, but it was a similar study with a little bit broader inclusion criteria. And the outcomes were pretty important, or the sort of upshot from this study is pretty important. The primary endpoint was a new thrombotic event over 36 weeks, rather than this sort of composite endpoint that we were dealing with in prior studies. Again, with a very wide non-inferiority margin here, and so that does make it a little easier for the DOAC to win, but it included both triple positive and lower risk patients. There were 190 patients enrolled with 95 in each arm, and a median follow-up time of 3 years. 60% of the patients were triple positive and 40% were not, with the vast majority of patients in the not triple positive group being lupus anticoagulant positive only. Like the TRAPS trial, there were more arterial events in the DOAC arm, 11% versus 3%, and no difference in VTEs. Of the 11 events in the DOAC arm, 10 of those were ischemic stroke, and none of the events in the warfarin arm were stroke. When you look at the subgroup analysis of the non-triple positive patients, again, about 40 per arm, there was no difference in thrombotic events between the two groups, with one event in each arm. This really makes you wonder if DOAC could be an acceptable option for folks who are not triple positive. But because it's a subgroup analysis and a relatively small number of patients, it's hard to make a definitive conclusion from this trial alone, but certainly suggestive that DOAC's okay.
And Dan, the interesting thing there, you mentioned there's 40 patients in in that subgroup in each arm. It's a very huge study. We think about the TRAPS trial. The trial stopped when there was about 60 patients in each arm. So it wasn't that there was such a low number of patients that we wouldn't have expected to see enough of these events occurring. It's very interesting that we're barely seeing any difference in these events in these low risk patients. I just find that pretty interesting. But Dan, what about now? Is there any ongoing studies looking at this DOAC question?
There is one looking at the use of apixaban versus warfarin. It's called the ASTRO-APS trial. The original protocol used apixaban at a reduced dose of 2.5 milligrams twice daily, with kind of weak justification. They said, oh, well, maybe there's some bleeding risk with it's an anticoagulant. You have patients who need anticoagulation, right? Like,
this is crazy.
Of course there's
yeah,
bleeding
it's like,
risk.
why would they design that?
After the results of the TRAPS trial came out, though, they amended the protocol to the correct dose, essentially, of 5 milligrams twice daily, which makes way more sense. And that's ongoing. We'll kind of eventually see what comes out of that. But I'm hopeful, based on some of the data that we already have, that these DOAC medications are going to fly for folks with a lower risk version of this disease.
So to recap what we just had talked about, warfarin is a clear preferred agent for triple positive APLS, no doubt about it, based on the TRAPS trial. We are not sure about patients who are not triple positive. And as Dan mentioned in that large Spanish randomized trial, but it doesn't have a fancy name like TRAPS, so people don't talk about it as much, the subgroup of patients who had single lupus anticoagulant or maybe 1 or 2 antibody testing that were positive, not triple positive, there was no difference in outcomes with DOAC versus warfarin in a total of 80 patients studied. So that was really a provocative finding. So Dan, is it absolutely necessary to transition everyone to warfarin? Is there any other real world data that we have that could maybe justify the use of DOACs in these patients?
So we don't have, like we covered, any prospective trials to help answer this question other than the subgroup analysis from that Spanish study. But there were a few meta-analyses and retrospective studies that do support the use of DOAC medications. We'll have links to a few of these examples in our show notes, but one notable example is a retrospective analysis performed at Mount Sinai in New York. They evaluated outcomes for patients who are persistently single positive for anticardiolipin, beta-2-glycoprotein, or lupus anticoagulant. So a little bit of a range of risks among those populations, but single positive disease. And these were patients who also had a venous or arterial thrombotic event between 2008 and 2020 and started on either warfarin or DOAC. Their primary outcome was the first recurrent thrombotic event. So they found similar rates of thrombosis recurrence between warfarin and DOAC patients, 6.6% for warfarin versus 5.8% for DOACs. 5 of the recurrent events in the warfarin arm were venous, 1 was arterial, and all of the recurrent events in the DOAC arm were venous. Similar results were also seen in a meta-analysis that included 9 different studies and a total of 1,131 patients. They did also note that triple-positive patients had improved outcome on warfarin in that study, but otherwise the results were similar.
Yeah, and I think that's the key, is that you mentioned 2 real-world analyses there that showed us, it confirmed our findings, right, that in triple-positive patients, got to use warfarin. It also kind of confirmed the findings of the subgroup analysis in the Spanish study, saying that DOACs might be okay for some of these other patients if they're not triple positive. Now, the Astro APS study, I think, is going to provide us a lot of really important information when that eventually reads out. For now, we're stuck with this, and often we err on the side of caution and just say, hey, we prefer warfarin. Now, if the patient tells you that, hey, I do not want warfarin, you counsel them, say, hey, look, it's probably fine. However, there is that risk. And what we're talking about the risk of, not a little DVT in your leg, a stroke or a heart attack. And those are 2 very, very big events that we see in these patients. So Dan, Ronak and I were going to have an argument on should we do inpatient APLS testing or not. So you got to take the inpatient side. I'll take the why we shouldn't do the inpatient side. So Dan, what are the pros of doing inpatient APLS testing? Let's say you have a patient, they come in, they have a PE, and they're young. And we talked about hypercoag workup in a prior episode. To you, what is the benefit of APLS testing in that patient in the inpatient setting?
Well, let's just put it this way, they're unprovoked, right? Like we don't have anything else we can really point to that says this is why a young person got a clot. In that case, and just majority of the time, we're putting this person on a DOAC medication, right? How are you going to tell that young person sitting in that bed that they need to go to the anticoagulation clinic, get their finger stuck, or they're more likely a venous blood draw several times a week, and then weekly, and then every couple weeks, and then every month, and get on DOACs and not go out to Sweetgreen with their friends and get salads? You're committing this young person to a fairly intensive medication regimen. I couldn't even take omeprazole when I was in med school. And so if we need to have a compelling reason to do this to somebody. And if you see that they have positive anticardiolipin, positive beta-2-glycoprotein, positive lupus anticoagulant, even if all of that stuff ends up being transient, on the chance that they do have true triple positive disease, do you also want that young person to go out and have a stroke because you put them on a DOAC? That's my reason. And I realize that you don't want to commit somebody to a chart diagnosis that they don't ultimately have. But I think as long as you have reasonable follow-up and you're committing this person to that it's very reasonable to send it in the right clinical scenario. It should not be orderable by non-hematologists. Sorry, guys, that's just how I feel. But I think when we think it's appropriate, then I think we should be able to do it.
So Dan, I'm going to push back on you a little bit here. So I'm going to take the devil's advocate approach, and this is just in the sake of conversation here. So I could make the argument that if you look at the TRAPS trial for triple positive patients, these arterial events were happening 200 plus days. So if you put a patient on a DOAC for 3 months, we would not expect them to have an arterial event. I would not expect them to have a stroke based on all of the data that we've seen in a prospective randomized study, that I'm not expecting them to have a stroke within 30 days. That's not the thing that happens to these patients. And why not just take them off their DOAC after 3 months for a hold and actually run the appropriate testing at that time point so that you can get a better sense whether they truly have APLS or not. And the reason why I say that is that patient does warrant hypercoagulable workup, although we may recommend indefinite anticoagulation regardless if they have an unprovoked event. There are reasons why a young patient you might consider that in. And for this case, I would not expect that to happen. The second thing is, let's say that we get all these antibody tests and all this fancy testing done, and they have one positive test. Now we're stuck with the situation. We have a lot of data saying that DOAC is okay. Now we're committing this patient to warfarin for life. in the absence of good evidence that we should be doing that. But it's hard for us not to do that because we say, well, you might have a stroke. And so to me, it's why I think that it makes sense to test later, because I'm not thinking that we're going to have these events early. And there is a tremendous risk of false positivity in the acute setting. And we are unable to run the lupus anticoagulant test that would really tell us if the patient's triple positive. So I think for those reasons, I think it's reasonable to defer to the outpatient setting. And, I think it's different if maybe the patient had an acute stroke and somebody's worried about, is this APLS in that patient with the stroke? Then I think you could make the argument to do it. Another hat that I would put on as a hematologist would say, just put them on warfarin for 3 months. It's 3 months, but then after that, you know what we can do? We can run the real testing at that point in the outpatient setting. They're safe because they're on warfarin, and we can get the appropriate testing at the right time and just put them on warfarin for 3 months. Yeah, it's 3 months, but it's not fun, but it's not your life. It's 3 months, and then get the testing in the outpatient setting. So I'm a big advocate that we do it all in the outpatient setting. If you have any clinical suspicion for APLS, in a stroke situation, an arterial event situation, you put them on warfarin. If I put them on a DOAC, I have good evidence that nothing's going to happen till at least 200 days plus. So I have time to get that testing set in the outpatient. So that's the way that I see it. Dan, any rebuttals to that?
Yeah, you know what? You're right. It's only 3 months, right? You're putting them on warfarin for 3 months. So if they have positive testing in the inpatient setting, you're only putting them on warfarin for 3 months until you get their repeat testing. But if they're negative, then you can put them on their DOAC and not worry about it at all. And the other thing I'd say is, let's do some math here. 3 months is 90 days. So if you wait 90 days to do their testing, then it comes back positive. Well, now you got to wait another 90 days. And I guess at that point, you don't want to keep them on the DOAC the whole time, but 90 plus 90 is 180. That's awful close to 200 when a lot of those events were happening. And so, I get it. I completely see where you're coming from, and I'm with you. I think that majority of the time, if we have an unprovoked clot and we're worried, you're getting a little sense, maybe your spider sense is tingling, that they could well have the lupus anticoagulant. Maybe someone in their family has autoimmune disease. Maybe there are some other risk factors that you're thinking about that makes them higher risk. Certainly wouldn't be unreasonable to commit them to warfarin because, again, functional testing can be done while they're continuously on warfarin. So maybe it's a better choice for that reason too. And you're right, we are very likely to generate false positives. These things happen transiently in times of stress. And to the extent that that adds to patient worry and sort of the anxiety that comes with potentially having a lifelong diagnosis with stroke risk, heart attack risk, pregnancy implications, I think that it probably on balance is better to wait if you can. So yeah, I have a hard time arguing this position because I generally agree with you. But those are the only things I'd say.
Yeah, I think this is a good discussion. I hope our listeners took something away from that, and that this is not clear cut. There's going to be different opinions on what to do. Neither way is right or wrong. The downside of sending too much testing, though, is overdiagnosis. Now, the patient is stuck with that in their head for life. It is much easier for us to say, oh, don't worry about it. The hematologist will explain it away. As a patient, it's easy for us. We did so much medical training, and we barely understand APLS, right? And that's the challenging part about this. As hematologists, we barely understand APLS. How are you supposed to expect a patient to do that? So I think this is a great discussion. Dan, thanks for taking that stance. I hope our listeners got a lot out of this, and I'll leave it to you for the final words for this episode and to wrap up this series.
Yeah, ultimately, I think this was we covered a lot of good data today. Definitely going to be one where you're going to want to go back to the show notes because we'll have links to all those studies and sort of an outline of the data for DOAC versus warfarin, all these things. The takeaways here, triple positive is kind of a special sauce within antiphospholipid antibody syndrome. It is a very high risk form of the disease. And similarly, folks with arterial events, those are populations that really does seem like warfarin is the gold standard here. Early suggestions, though, are folks with lower risk version of the disease, single positive, venous-only events, are probably going to be fine with DOACs. We just don't have the prospective data for it yet. So stay tuned, and we'll hopefully have that data soon. And maybe when that comes out, we can do a follow-up episode. I certainly want to get a little bit more into the different forms of antiphospholipid antibody syndrome in the future, but I think at this point, our listeners probably need a little break from benign heme. We've had a lot of episodes in a row, so maybe for our next benign heme interlude, we can revisit some of the different subforms of antiphospholipid antibody syndrome.
All right, that wraps up another fantastic series of the Fellow on Call. Next up will be follicular lymphoma. Everybody get ready. I'm super excited about it. We'll see everybody next time.
Peace.